Good afternoon. My name is Christina Marshall, and I'm the Director of Surgical Operations at Pain and Spine Specialists of Maryland. This is Dr. Sudhir Rao. He is the Medical Director and Facility Director of the center. So, Dr. Rao, I've been getting some questions. People will stop me on the street because we had a got pain shirt and like, what is PAS? So, how would you quickly describe what Pain and Spine Specialist is?
So pain and spine specialist is a comprehensive pain management practice. And what that means is that we treat the whole body, the body and the mind, and we treat patients with chronic pain with medications. We refer to physical therapy and chiropractic therapy. We also perform our own procedures on patients to really improve quality of life and improve overall functionality. And if we need to send out or refer out to our surgical colleagues, we help patients find the right fit.
Okay. And I know that patients will ask us about different procedures that we do and why we do them, and why do we do this procedure versus that procedure based on the pain that they have. So I know one of the biggest questions about spinal cord stimulator, like, am I a good candidate? What makes me a good candidate? So how would you explain that to your patient?
So spinal cord stimulation in general is a way for the brain to not feel chronic nerve pain. And nerve pain is going to be that burning, throbbing, shooting type of pain that has not responded to medications, physical therapy, injections, and sometimes even surgery. So patients can have post-laminectomy syndrome or lumbar post-laminectomy syndrome or that has not responded to lumbar spine surgery. So patients have had back surgery, they're still having burning, throbbing, shooting pain down their legs, they're having that ongoing back achiness. And for those conditions, we can try epidural steroid injections, we can try radiofrequency ablation, we can try physical therapy. But when those modalities don't provide the type of relief we're looking for, then we think about something called spinal cord stimulation. And the point of stimulation is to change the way the spinal cord and the brain feel pain as well as transmit pain. So back in the day, it used to be you would feel a tingling type of sensation or a buzzing sensation. And in the last 5 years or so, that's changed. Technology has significantly changed and continues to change every year for us to get better outcomes and provide this stimulation through different ways. So now people don't no longer have to feel the stimulation. They can if they want, but we're finding more patients don't want to feel it and they don't have to. They just feel less pain. And the goal is if we can block certain nerves around in the spinal cord, we can then get that change in how the brain senses those signals. It changes people's lives. It really improves their overall functionality.
And you do spinal cord stimulator here?
Right, yeah, so it's a fairly simple outpatient procedure. We do it here in our office. We do it under sterile technique. It's a 3 to 5 day, maybe even 7 days at times, trial period to see if this is something that really is going to work. So unlike other things or other types of procedures or surgeries, this is not something that we quote patients a percentage that they're going to get better. It's more of us saying, hey, we think this is a good option for you. This is the type of procedure. This is the conditions it treats, but let's give it a whirl. Let's do a test drive to see if this is something that's actually going to give you the type of relief that you specifically need. So it's individualized to each patient. And we're looking for about 50% improvement in pain, but also in functionality. So were you able to sleep longer? Were you able to climb that flight of stairs? Were you able to go to get the mail from the mailbox? Were you able to play with your kids or your grandkids? Subtle things that can really transform people's lives that are hard to quantify. Unfortunately, when patients come in, we ask them, what's your pain score? And how much better do you feel today? What type of percentage relief do you have? What we're trying to get to is better understand what's causing the pain, what interventions or what medications, what have we done that has actually made a difference? And it's really hard to quantify that. So instead of us saying, hey, this is what makes you a good candidate to move forward, this allows us to do a test drive or a trial, see if it helps, and the patient gets to make that decision of whether or not it was worth it for them to go forward with a surgical implantation for the permanent stimulator.
So what about those patients that are currently on pain medications and they've had a successful trial? Then you refer them to a surgeon and they've had it implanted and it's successful. Do you cut the patient off altogether? Are they no longer a patient, or how do you proceed with that?
No, so spinal cord stimulation is adjunct or in addition to what we're already doing. So if patients have been on chronic pain medications and they're helping, but they take the edge off, they still have that breakthrough pain, they still are limited in what they can do, and or they just want to be on less pain medication, then stimulation is a great option for them. Let's fast forward, they go through the trial, they get the permanent implant. 5 months later, we're starting to ask them questions about how much better do you feel and what's your quality of life like? How much pain medication are you still taking? Do you still need to take just as much? And the answers vary. Some people are able to drastically come down off their medications, but that's not necessarily the goal or the reason to get the stimulator. The reason to get the stimulator is to get you feeling better and get you more functional. If that means we have to continue the pain medication, then so be it. But we're doing it within a reasonable, compliant way. We're making sure that we're prescribing the right amount of medications and we're monitoring to make sure that it's actually helping. So not everyone who has a stimulator means you have to come off your pain medications. Pain medications and stimulation can work hand in hand and get you feeling better.
So then what is the difference between a spinal cord stimulation trial and a dorsal root ganglion stimulation? What is the difference between those?
So there are multiple different types of stimulation that's coming out to the market now. Spinal cord stimulation is the most traditional. It's been around for a very long time. It stimulates the dorsal columns, specific parts of the spinal cord. However, dorsal root ganglion or DRG stimulation is a newer form of stimulation, which has been around for about 5 years or maybe even longer. What that does is it specifically targets a specific part of the spinal nerve as it leaves the spine. So if you look at the model here, we've got bones, we have discs in between, and we have little spinal nerves. And there's a little bulb on these spinal nerves, and that's the DRG, that's the dorsal root ganglion. That's the part of the nerve that actually has the sensory fibers that send those signals, those pain signals to the brain. So DRG stimulation is specifically targeting those nerves and that part of the nerve. It's very good for patients who have complex regional pain syndrome or CRPS. It's good for knee pain, hernia pain or groin pain, abdominal pain, specific nerve root types of pain that have not responded to either traditional spinal cord stimulation, surgery, injection, or nerve blocks. So it's another option that we have.
So another question that I've been asked by patients is if they do move forward with one of the, or the other stimulation, can they turn it off, or does it stay on constantly?
No, so they have control, and they have a little remote control that they go home with. They can use that remote control to turn up, turn down, turn on, turn off. But we have found that more times than not, with the newer technology, they don't feel anything, so it's just on. And if they need to tweak it and they want to make some changes, they can play with the remote to do that. But we're finding less and less patients want to do that or need to do that. Now, the older type of systems where you felt the stimulation, they would change the program, they would change the intensity, and they had a lot of control with what they want to do. Those systems are still available, and you can do both if you need to.
So you refer back to the older systems of the stimulation. Now, just say patient had an older version of this decades ago, and it's no longer working, or they no longer like it, and they want to try something. Do they have to get that surgically removed?
No, so if they've got an older system, the system is two pieces. It's the wires or the electrodes that go in the thoracic spine or the middle back, and then it's the generator that looks like a smaller hockey puck that is the battery itself. If you have an older system in place, the electrodes can be left alone. You don't have to mess with that at all, and you can just have the battery surgically replaced, which is 15 minutes outpatient quick surgery. Every so often, the batteries themselves need to be replaced anyway. So if your battery life is not working as well and needs to be replaced, then instead of, we can basically upgrade your system because it's time for you to get a new battery anyways.
Okay, and so they're both trials. So that's not, you don't go right to permanent, so they're both trials, correct?
The DRG stimulator is a trial, the spinal cord stimulator is a trial, right? So we are trying it out to see if the patient tells us it's giving them enough relief to move forward with the implant. So
then the process would be, you find a good candidate, and then what do we do? We just put them on the schedule, or what are the steps following or preceding, to have this procedure?
To define a good candidate first, anyone who's got burning, throbbing, tingling type of pain that has not responded to Neurontin, gabapentin, Cymbalta, Lyrica, nerve pain medications, traditional pain medications, anti-inflammatory medications, physical therapy, chiropractic therapy, injection therapy, and or even surgery. So if you've done all these things and you haven't gotten better, then spinal cord stimulation is an option if you have ongoing back pain and leg pain. And I want to add neuropathy also.
Yes.
So neuropathy has been something that we have really had a lot of trouble treating for a long time. We've been using spinal cord stimulation to treat neuropathy for a very long time with great success. And now the FDA has approved spinal cord stimulation for treatment of neuropathy, which is great. And something that we've known, something that we've been doing for a long time, but now the FDA also validates that it's an effective treatment. And the great thing about it is because neuropathy is so much nerve pain, that burning, throbbing type of pain, the pain that is on your legs and you can't sleep, the sheets hurt, you've tried all these medications, stimulation puts all that to rest and calms those nerves down. So what's the process? We have a patient who comes into the office, we talk to them about it, then we have to start the process to get authorization from the insurance company. Now, most insurance companies nowadays want the patients to get a psychiatric or psychological evaluation just to make sure that they are aware of what's going on and they have a reasonable expectation of what is going to happen. So we have our own counselors and psychiatrists on board here that can help with that process. If the patients have their own counselors or psychiatrists, they can get that psychiatric evaluation done. It's a pretty simple process. It takes maybe 30 minutes to do. We then submit documentation, which includes an updated MRI of the thoracic and lumbar spine, the paperwork, the psychiatric evaluation. We send that all to the insurance company to get authorization. Once we get the authorization, then we get them scheduled for the trial. And that can take a couple of weeks to get scheduled for the trial. The trial itself is 3 to 7 days. The trial can be done with anesthesia. You can be sedated for it, or we can do it under local, where just a lot of lidocaine and other anesthetics. Both ways work very well. It's just a matter of what patients prefer. That trial period is 3 to 7 days. Once you come back to get the leads removed, we just tape on your back. So we just take the tape off, we slide the wires out, and then if it was a successful procedure and the patient wants to move forward, we refer them to a surgeon. And we have many surgeons throughout all of our areas that we practice in that have vast amount of experience with spinal cord stimulation, enjoy doing these types of treatments and have very good outcomes that we can then select and help patients get scheduled and make sure that all of that is complete for them.
Yeah, so I always explain to the patients as well that we network with the best surgeons. So if they have a great successful trial and they have a problem getting into their surgeon in a soon enough manner, that the staff will help them, give them a call and try to fast track that with the surgeon.
Absolutely. The patient's gone through the trial, has gone through the hard part of it. We want to make sure they get in and get the implant done as soon as possible for their own benefit.
Well, thank you for going in more detail about the stimulation trials. And so we should move on to
Dr. Al will be joining shortly. He just got kicked off right before the Q&A. So he's trying to rejoin, and then we'll get started and we'll proceed with questions. So if you have any Q&A questions, you can submit them through the Q&A box and we'll get them answered one by one.
All right, how's everyone doing? Any questions? Is this good for knee pain and groin pain? So different types of stimulation can be options to treat these other types of areas. So we have also, not only is it called spinal cord stimulation, but we also have something called peripheral nerve stimulation, which can specifically treat pain in the knee and the groin as well as the shoulder. What about sciatic nerve pain? Can spinal cord stimulation help sciatic nerve pain? And the answer is absolutely. For sciatic nerve pain, we usually try to treat that with epidural steroid injections to start with. And if these injections do not provide adequate relief, and if the patient is not a candidate for surgery, then spinal cord stimulation is a great next option. The idea is we're trying to block the pain signals that are going from the leg to the brain, and sciatica is nerves getting compressed or irritated or inflamed by discs irritating the nerves in the lower back. So spinal cord stimulation is a potential option. Question is, what do we do when a surgeon is saying you can do a stimulator or surgery, and that gets a little tricky. I would say if the surgeon feels that there's a better outcome with spine altering surgery, and that will relieve the compression on the nerve, then I think surgery is a better option. However, that's not always the case, nor is it that clear cut. So if the surgeon is saying, well, you may have some improvement with this procedure, may have some improvement with the stimulator, then I think doing a trial, a spinal cord stimulator trial before surgery is an option for sure. There's not a lot of potential downside for trying the trial itself. It's a 10 to 20 minute procedure, and if it can help us get your pain better controlled and for you to help potentially avoid spine altering surgery, then I think it well is a good option to consider before surgery. Traditionally, the thought process was this is a treatment for patients who have had back surgery and have failed, and is that the only way to be able to use a stimulator? But that thinking has been changing, and we'd like to be able to offer these services if insurance approves sooner than later. My pain is more achy lower back pain. Next question. My pain is more achy lower back pain. Can spinal cord stimulation help this? And the answer is absolutely. When lower back pain does not respond to epidural steroid injections, radiofrequency ablation, maybe even sacroiliac joint injections, then the next step to consider is either surgery, or would consider spinal cord stimulation. And historically, I would say over 10 years ago, the technology was not that great to be able to get ongoing sustained lower back pain relief. But that has significantly changed in the last several years. And we're getting better and better back pain coverage with spinal cord stimulation. So I definitely think it's worth considering. Next question, what devices interfere with spinal cord stimulation? That's a little trickier question. I think if you're around high levels of electromagnetic activity, then that's a problem. So if you work in these monstrous supercomputer rooms, we do caution patients about that type of work. But as far as using heating blankets, heating pads, warming up food using a microwave, none of that has any type of interference. Next question, is it approved by Medicare? Yes, it is approved by Medicare for as late last resort therapy. It is approved for post-laminectomy syndrome or failed back surgery syndrome, which means that you've had back surgery and you still have these types of this painful condition. It's approved for diabetic peripheral neuropathy. It's approved for complex regional pain syndrome. And it's approved for any type of trunk and limb pain. So mid to lower back pain with radiation into your legs that has not responded to more conservative treatments. It is an approved treatment option. And most commercial insurances, as well as some Medicaids, will also approve it for these reasons. Okay, I think that was the last question. Once again, thank you very much for joining us. If you have any questions, feel free to come in and ask us. We appreciate you taking the time out of your busy days to listen, and we're happy to help spread the word and educate everyone on different ways of treating chronic pain. Stay tuned for our next webinar. Take care. Have a great day.